Should we give a couple of more minutes until people join?
Yeah, please. No worries.
Shall we start, Sindhu?
Yes, ma'am, I think we can start.
Yeah.
Ma'am, shall we start, ma'am? Okay. Yes.
A very good evening and a warm welcome to each and every one of you joining us today. As we stand at the threshold of a brand new year, 2026, it is our absolute pleasure to welcome you for the first session of Scale Masterclass Series 2026. On behalf of Sri Chakra Academy of Learning and Education in Fertility, we wish you all a very happy, prosperous, and academically enriching new year.
Welcome, everyone. 2025 was a landmark year for Scale, where we started and shared immense knowledge and fostered a growing community of fertility experts. Today, we begin 2026 with an academic extravaganza, setting the stage for a year of even greater heights in reproductive medicine and embryology.
And to begin this journey on an auspicious note, let us seek the blessings of Almighty. And I request everyone to join us in the spirit as we commence with a prayer song. Pound? Volume, we are not able to hear. Are you able to hear, Sindhu? We are not able to hear the audio.
Clear, ma'am.
Can you hear?
Yes, ma'am.
Okay. Yeah, Sindhu.
So, moving forward, it is a moment of great pride that we are thrilled to release the Scale 360, which is a summary of our academic journey of the year 2025. This edition is not just a document, it is a celebration of the glimpses of 2025 and a roadmap for what lies ahead of us.
Next, Pound. Yeah. Just keep scrolling. He's just showing you the overview of the newsletter. We'll be sharing this in a PDF for all of you to just go through. Go ahead, please. Yeah. So the next one. So we are extremely happy to announce that Scale 360 is going to unveil a new academic planner for 2026, which is there in the newsletter itself. So we are coming up with two unique programs in 2026. One is a very prestigious program, which is called as Elevate 2026. This is going to be a rapid revision course for the students of embryology, both BSc and MSc clinical embryology, or anybody who is pursuing embryology program at a basic or master level, and also a 2-day revision course for reproductive medicine students, MCH reproductive medicine, FNB students, ICOG fellowship students, and anybody who is doing fellowship in reproductive medicine. It's going to be a rapid revision before their exams. So it's a 3-day program totally, and all the details we will be sharing. And it is one of the kind of a program which, many of the students will be benefited, and it's uniquely curated based on the syllabus and the curriculum each university has prescribed for their particular exams. The other unique program that we are coming up with is the Scale Campus courses. We are going to have 4 campus courses. then the details of which is there. It's in April, we are having about IVF. In June, it's on medical management of male infertility. In September, it is a day in the life of an embryologist. And in December, it's going to be translational reproductive physiology. Go ahead, please. So I would, today, it is indeed a more special day for us. Go ahead. Yeah, so you can find all the details about the programs in this brochure or any of these links, which you can, go through all the details of all the academic activities which we are going to do in 2026. Sindhu?
Yes, ma'am. So like ma'am mentioned about Elevate 2026. And so today is even more special because we have the distinct privilege of having our expert speaker, Charulata ma'am. Then before we go into today's session, the next masterclass is on the 29th of January by Dr. Parasuram Gopinath sir on do stimulation protocols influence oocyte quality, maturity, ploidy, and outcomes as a continuation of ma'am's class today. So today, ma'am's going to talk about oocyte quality across patient populations and how it affects the lab KPIs.
Before we introduce the speaker, ma'am is a well-known expert. I would like to take a moment and specially recognize my technical team. An academic program of this scale is only possible with a strong foundation, and I must take a moment to acknowledge the tireless behind-the-scene efforts of Mr. Krishnamurthy Reddy and Mr. Pawan Kumar. Indeed, they are the masterminds behind the seamless IT execution and the beautiful design of Scale 360 degrees. Their technical support ensures that our knowledge reaches the delegate without a hitch. And we sincerely thank you for your dedication and tireless efforts for seamless execution of Scale education program. So without much ado, now we can delve into the topic. And I would like Dr. Sindhuja to please introduce Dr. Charulata Chatterjee and begin our 2026 Masterclass series.
Yes, ma'am. So, Dr. Charulata ma'am, before I go into actually introducing ma'am, she's a very kind person, as most of us know her, and she's a very warm and welcoming person. Madam is the scientific head and consultant embryologist at Medcy IVF, and she's a top class. She has a top class experience for the last 25 years in the field of ART and has many publications in national and international journals. Madam has been the EC member of ISAR and past EC member of ACE and past joint secretary of IFS Telangana chapter. And Madam is a faculty and a very well-known speaker at various workshops, CMEs, and conferences. And we look forward to her session always. And very lovingly, she's the mother of 2 children and lives at Hyderabad. And Madam has many achievements to her credit, like the ISAR Guru Award, IFS Achiever Award, and ISSRF Excellence Award. So, ma'am, very, very warm welcome to you. Please kindly take over the session, and thank you for accepting our invitation to be the first speaker of 2026.
Thank you so much. First, let me just, say thank in advance only that Scale is doing so wonderful academic activities and a complete team, Dr. Vasundara, Dr. Sindhuja and your team. I heartily congratulate you and entire your team for continuing, spreading the knowledge among colleagues and for students. So, shall we start today, Sindhuja? Yeah. So let me just share my PowerPoint presentation with you. Is it visible to everyone?
Yes, ma'am.
Yeah. So I'll start on the slide share, please.
Ma'am, please click on that. Yes, ma'am.
Yeah. So
Yes.
I will just
Yes.
put it on a slide share. Is it visible?
Ma'am, it's visible, but we can see you in the presenter mode. So I can see your next slide.
Just a minute. Give me a minute.
Yes. Can I say something, ma'am?
Yeah, please.
You can stop sharing, ma'am, and then you can just share the presentation instead of sharing your entire screen. So you will be able to see the presenter mode, and we will only be able to see the slide.
Yeah, 1 minute.
Yes.
Slide. ये पूरा ये नीचे कर दे.
Your voice is muted, ma'am.
Ma'am, if you can click on the display settings, ma'am.
Yeah, 1 minute, please.
Yes.
Soon.
Yeah, 1 second. I'm just trying to figure out slide control, annotate, scale. No, so slide control.
You can turn off the presenter mode alone, that's all.
I'm sorry, where's the presenter mode?
So you go to the display settings on the top, I can see just above the current screen.
Display
Okay.
settings.
In slideshow, display settings is.
Oh, there you go. Perfect.
Yeah,
Yeah, I'm sorry for delay.
no problem, ma'am.
Perfect. Let's go.
So, the wonderful topic has been selected by your team, that is oocyte quality, and how it will affect our lab KPI, and what are the factors, either internal or external, which affect oocytes, these things. So, what today we are going to discuss the oocyte quality and its biological determinants, patients populations associated with variation in oocyte quality, how in the role of laboratory as an embryologist we cannot change the quality of the oocyte, but we cannot further deteriorate it, so that how the strategies we should plan to mitigate the poor oocyte quality. So these are the few topics which I have mentioned here, that I'll try to cover in my this presentation. So as an embryologist, the first thing when the drop of follicle fluid is coming to our lab, the first question is asked by the clinician, that how does the quality of the oocyte, and what's the developmental potential. Whereas couple undergoing will also ask that does our eggs looks healthy, and will it be suitable for the fertilization. And we feel like, oh, how to, because sometimes the morphology can deceive. Just basic, we'll try to brush up all the foundation, so that we can quickly brush up that oogenesis. It's a part of the gametogenesis, and every girl has born with a definite number of the eggs, and it will be arrested at meiosis 1, And once the ovulation occurs and it fertilizes, the second polar body and the meiosis 2 will start. So this is a very basic steps of oogenesis, whereas in a follicular genesis, the primordial follicle, primary follicle, preantral follicle, early antral, and mid-antral. And these are all the steps where the development of oocytes occur into the follicle and the maturation takes place. So these are the follicular genesis steps. Suppose if I have tried to define oocytes in a various way, it is easy for, give the explanation that why oocytes and quality the oocytes if you define the oocytes in a different way. So the best way to define the oocytes is a morphological definition where we understand the normal structures, the perivitally space, the external cytoplasmic features, internal cytoplasmic features, and all that. Then, if you define the oocyte in the biochemical definitions, we see the lipid droplets. Molecular definitions means the DNA is intact and what are the steps of the mitochondria maturation and all that. Then there will be a metabolical definition. So generally the oocytes will get mature into follicle by this. So if you understand the follicle fluid and follicular genesis, there are some markers that can give little insight about the quality of the oocyte. So these are the different way I try to define the oocytes so that it is easy for us to understand the biology of the oocyte. Coming to the morphological aspects of the oocytes, these are the few oocyte maturation points. So if you see the oocytes, first we see the cumulus mass appearance, the nuclear maturity, the appearance of the first polar body, the presence of meiotic spindle, and the oocyte size, which is visible under the microscope. If we see the intracytoplasmic aspects of the oocytes, what the features we observe? The granularity of the cytoplasm, the vacuoles, smooth endoplasmic reticulum, and refractile bodies. The extracytoplasmic aspects, we see the shape and the perivitally space and the ZP, whether it is thick, thin, dark, and all that. So these are the three categories to look for the oocyte morphologically, and how it affects the outcome one by one we will see. So as oocytes, what are the consensus we follow to categorize dysmorphism or a oocyte quality? We follow alpha consensus, Vienna, and we do have our ESR consensus, which will give the guidelines to morphologically define the oocyte. Now, if you define the oocyte based on the cumulus mass, in the under the stereosome microscope also, the GV oocyte, the corona cumulus, will be such a compact and little dark. So you can see without denudation also, you can predict that this oocyte might be a M1 or a GV. Whereas if you see the oocyte which is mature, which is in the second picture, you will see the sunburst kind of structure, and that oocyte will be mature, whereas post-mature the oocyte which is going to be atretic will have dark and loose corona cumulus. So this is the one way to predict the maturity of the oocyte in a cytoplasmic level, of course, and the molecular level we see after the denudation, after seeing the appearance of the first polar body. Now, what are the factors which can be predict about the outcome? So, if you find the blood clots associated with kind of cumulus, that blood clots will increase the level of oxidative stress, and that might affect our fertilization rate. So, whenever we embryologists see the corona cumulus, even we should not wait till we denude the oocyte if it is with the blood clot, because at denuding time we are culturing oocyte maximum for 2 hours. So it will increase the level of oxidative stress. Better to cut or the get rid of that blood clot and then culture the oocyte before you go for the denuding. Whereas nuclear maturity, we can see after the denudation. I do not have to tell. Everyone knows about the GV or germinal vesicle is immature. The M1 will not have the presence of first polar body, whereas the mature oocytes will have the first polar body and the good cytoplasm. Now, appearance of the polar body, does it affect the fertilization rate? And what are the different types of polar body we observed in an oocyte? So the first picture says it's a good round polar body intact. In the second picture, if you say the polar body is very large, whereas in the third picture, it's a fragmented polar body. How it affects will come into the subsequent slides. The meiotic spindle, generally the meiotic spindle cannot be visible under the normal microscope. It needs a special microscope to see the spindle, but generally we believe that spindle will be below the first polar body. That may be the reason that when we are doing the ICSI, we keep the oocyte at either 12 o'clock, polar body at 12 o'clock or at the 6 o'clock, so we should not damage the spindle during the ICSI procedure. There are various papers if someone wants to see, and generally the if you see the angle when you freeze the oocyte and see, that might be the meiotic spindle location might change. So this is the paper. It says that the degree of the meiotic spindle from 0 angle to 90 degree angle. So till 645 degree angle, it will not affect, but if it is more than 90 degree, it is going to affect your fertilization rate and the cleavage rate. Now coming to the oocyte size, sometimes we see generally the oocyte is 100 micrometer in the size, but the larger or the giant oocyte will be double the size, it will be around 200 micrometer. So around 0.3% of the retrieved oocytes in the stimulation cycle may be a giant oocyte. So this giant oocyte will be chromosomally abnormal, and we should not, even if it is fertilized, we should not give first preference to transfer, and we should kept it separately. So this is the about the giant oocytes. Now coming to the intracytoplasmic abnormality and the extracytoplasmic abnormality. Intracytoplasmic abnormality, many times we observe there is a centrally granulated cytoplasm, or sometimes we also call it as a brown oocytes. So if you experience, embryologist has experienced, and when they are doing the ICSI, the funnel formation or what we call is channel formation, it should dissolve within less than a minute. But such kind of oocyte takes little longer time, and if it is taking little longer time, these oocytes maybe has the kind of aneuploidy rate, so maybe higher aneuploidy rate. So this centrally granulated cytoplasm, which is dark or which is viscous, we should use it with the caution, and is preferably culture separately. Then there is a vacuole. Vacuoles are different in the size, and these vacuoles can arise spontaneously. It can also arise from the endoplasmic reticulum or sometimes unintentionally. So these vacuoles, oocytes, can be also cultured separately if it is a larger vacuole. So minor vacuoles, it can be, oocyte can have the repair mechanism, it can repair. Coming to the central, smooth endoplasmic reticulum, in my experience, I have observed the patient who has a high value of estrogen during the stimulation. In that cohort, the oocytes retrieved are more of having the SER disc than the normal estrogen level. So this SER is also having the, affect the blastocyst formation rate, and so do the refractile bodies. Coming to the shape of the oocyte, generally the shape of the oocytes will be round, but sometimes it will be a oval, or very rarely we observe the twin oocytes also. So this also has to be kind of take it with the very precaution. Then there will be another feature of extracytoplasmic abnormality which we commonly observed in many IVF cycles, patients undergoing IVF cycles, that there will be a large, one kind of abnormality is a larger PVS. And the another kind of abnormality, there will be a debris into the PVS. So this kind of abnormality, whether it will affect the fertilization rate or cleavage rate, it's a matter of debate. Some few papers says that the granular coarse granules or a debris into the PVS will affect the implantation rate and the pregnancy rate, and few papers says it won't affect. How do we see this abnormality, and how? So Istanbul, the recent consensus has given very clear kind of search research data that the table color code is green, is you can go ahead with this. Yellow means with the precautions, and the pinkish shade will say that this oocyte, preferably even if it is developed into the embryo, we should not prefer for the transfer. So the first abnormality is about the corona cumulus. As I have discussed earlier, the presence of blood clots is associated with the lower fertilization rate because it will increase the oxidative stress. Then there is a ZP. ZP, either there will be dark ZP or a thick ZP, that is also associated with the lower fertilization rate, but there is no clear association with the blastocyst formation rate. Coming to the perivitellin space, large perivitellin space in PVS, we see the two kind of abnormalities. One is large PVS and another is granulated PVS. So there is no clear association with the lower fertilization rate because it is extracytoplasmic abnormality, and there is no association with live birth rate and implantation rate. A polar body, a fragmented polar body, and the large polar body. The large polar body is associated with the lower fertilization rate, whereas fragmented body, there is no clear indications which affects the fertilization rate or subsequent blastocyst formation rate. Coming to the vacuolization, it also affects the fertilization rate, blastocyst formation rate, but there is no clear data on the implantation rate. The presence of refractile bodies also having no clear association either with cleavage rate or the blastocyst formation rate. Smooth endoplasmic reticulum also generally during the ICSI, we should not rupture the SER. If the injecting needle, we should take care. Then there is no association with developing embryo and the live birth rate or a pregnancy rate. Granularity, definitely it associated with a lower fertilization rate and as well as blastocyst formation rate. That's why I said that there is a spongy dark brown cytoplasm that indicates the aneuploidy rate is higher in that, where if the patient is going for the PGTA. The morphological what features we see is a shape, color. So the shape is either not the oval, but and that also ooplasm is dark. So, but there is no clear cut. It affects the developing embryo. Immaturity, we all know that mature oocytes which having a clear cytoplasm with intact polar body is best for the giving the best quality of embryos. Whereas oocyte size, see this is the pink color, a clear pink color. The oocyte either smaller than 100 micrometer or a giant oocyte which may be above the 180 micrometer, that is having a very low potential for fertilization, and it should be avoided because that is going to have the chromosomal abnormality. So what are the take home messages after this Istanbul consensus are: the giant oocyte should be excluded from the clinical use, that is loud and clear. The small or large oocytes or IVM rescued oocytes should be documented and with precautions. IVF derived from M2 oocytes are having a good potential for the and developing embryos will having a good potential for the implantation. So these are the features from the 2025 Istanbul Consensus. Now, what we feel that oocytes we have retrieved, what we are not going to the if it is the quality of bad, that we are not going to make it convert it into the good oocytes in the lab. So what is the need for the assessment of the oocyte morphology and quality, that we should know. So as I told you that if we cannot do anything about the quality which is having that internal affected by the internal factors, but we should not as an custodians of a gamete or an embryo, we should not further deteriorate it into the lab by culturing in a compromised condition. So what is the need for oocyte quality assessment? Because oocyte quality is a major determinant for the fertilization, embryo development, implantation, and also for the live birth rates. The poor quality is associated with failed fertilization, poor embryo formation rate, maybe aneuploidy, and it may have the miscarriage rate. So the quality assessment will help us to select the competent oocytes. We can optimize the ART outcome and we can understand the age related changes happening in oocytes. So it will reduce the multiple embryo transfer and emotional and financial burden on the patients. So how do we assess the oocytes? So there will be invasive methods and the non-invasive methods. So what are the non-invasive methods? One of the method we have just discussed in detail. It is a morphological assessment. Either it's the corona cumulus or intracytoplasmic or extracytoplasmic abnormality. We clearly can assess under the microscope about the morphological assessment. Then there will be a second is a polar body assessment. The third is a spindle imaging. If we have a spatial microscope, especially when we are, using the frozen thawed oocyte, it might change the location of the spindle. In that case, the spatial microscope we can use for the spindle. Then there will be a time lapse and there will be a metabolomic profiling of the follicle fluid. But these are the fifth one where we check that metabolites, amino acid, glucose or lipids, that are little costly and it needs expertise and expensive instruments. So it is not very popular into the common use. It is only used for the research. So non-invasive oocyte quality, as we told that omics is also one of the popular thing, whereas as long as embryo grading is concerned, but only for the oocyte, it is not regularly used in the laboratory where we use the genomics, transcriptomics where we use the mRNA profiling from the cumulus and granulosa cells, proteomics where we check the protein expression from the follicular fluid, lipidomics, secretomics, epigenetomics, and these are the different non-invasive oocyte quality assessment tests. Probably, maybe in the future, it will be coming into the regular use, and we can predict the oocyte not only from the morphology side, but other non-invasive methods by omics method. The invasive methods for the checking of the quality of the oocyte is cytoplasmic and nuclear staining, mitochondrial assessment, chromosomal analysis, gene expression analysis, and level of ROS measurement. But this is only for the research phase, so that we can, after this having the research on number of oocytes, we can predict that such abnormality will have, because we are not going to use any invasive oocyte quality assessment for the routine purpose. Now, what are the factors which affects the quality of the oocytes? there must be some internal factors, there must be some external factors. Internal factors, either we can check with the change with the medicines or something, or external factors also can be modified and one can have the good quality of the oocytes. So we'll see many of in my presentation, I have made it so many tabular form just to cover all the small points, because otherwise the presentation will be very long. So I do not want to left any point unattended. I have made many of the tabular form. So factors which affect the oocyte quality, if you check the internal factors, it will be first and the advanced maternal age, genetic abnormality, oxidative stress, hormonal imbalance, POR, and other blood flows and autoimmune disorders and like that. Whereas external factors, that is lifestyle, smoking, consumption of alcohol, endocrine disruptive factors like pesticides and environmental toxin, air pollution, and so on. There is no like in any from the day our start the day, and we are covered with so many external factors which will affect the reproductive potential of the woman. So, the patient-specific factors which affect the oocyte quality, the first is advanced maternal age. How it will affect the oocyte quality? It will increase the meiotic error and it will reduce the mitochondrial function. That is the reason now we have that, mitochondrial exchange, that is advanced method. And the oocyte, the resulting oocyte might having the enlarged PVS and the cytoplasmic granularity. In case of poor ovarian reserve, that will be a because oocyte having the reduced follicular competence and maturation capacity. So that oocytes might having the different size and the dark cytoplasm. The PCOS, we know that is because of the hormonal imbalance and the altered follicular genesis. Thick ZP, vacuole, SER are all other the features. Endometriosis, obesity, diabetes, hormonal imbalance, genetic abnormalities, oxidative stress, lifestyle, and so on. So I have tried to cover all the patient related factors and what are the changes it happens into the either at the follicular genesis or at oocyte maturation, and what are the abnormality if you observe in such kind of patient specific factor. The first is egg quality. As we all know, every woman has been born with 1.5 million of the eggs, but by the time of she reaches the age 30, that will be around 12%. So it is a clear cut indication that advanced age, and particularly for the Indian woman after the age of 35, the quality and the quantity of the egg will be compromised, and basically it will lead to the aneuploidy, and that might be having the implantation failure or even might land up into the miscarriage. So this is the clear thing that we say that either you be a mother or you can preserve your fertility before you go ahead with your advanced age. The low ovarian reserve, normal ovarian reserve, and the poor ovarian reserve is also one of the factor which might affect the oocyte quality. The patient population, sometimes it may be because of the advanced age, it may be because of the history of early menopause if the woman has having history, or maybe the patient has a previous ovarian surgery or endometriosis. These are the patient population which have the poor ovarian reserve or the less ovarian reserve. That will be also changes the mitochondrial function into the oocyte. That will also affect the developing embryo, and what are the option for this lady is either we pull the oocytes in the dual stimulation, or we can just having repeated minor mild ovarian stimulation. We can either pull the oocyte, freeze the oocyte, and then after 2 or 3 cycles we can develop the embryo, or we can develop the embryo and freeze it and transfer into the subsequent cycle. This will be the ART strategy for this kind of woman who is having a POR. So in case of POR, what are the indications? AMH is one of the factor which can be, say that the level of the AMH, because AMH plays a important role in the recruitment of the primordial follicles. That's why we, along with FSH and LH, AMH is also a good indicator, with also scanning when we say the developing follicles on the day 2. But AMH is also one of the good factor to indicate that patient is having the poor ovarian reserve. It might affect the quality of the gamete. Can PCOS affect egg quality? Of course, PCOS is having affecting egg quality because of the hormonal and metabolic disorder. So, definition I do not have to say because we all are from the ART industry and professional. It is endocrine metabolic disorder. Maybe it is characterized with the, kind of many follicles development into the ovary. There is no, like there is a thin PCOS, obese PCOS, and that might be clinician will relate more. The follicular development will be arrested, that will be having the elevated FSH, LH and FSH ratio. The oocyte may be, because there are many follicles developing, there must not be a many mature oocytes. And for this kind of PCOS patients, we have to individualize the ovarian stimulation protocol, probably mild or antagonist protocol. We have to use the add-on therapy like some lifestyle modifications, or metformin or other options to improve the quality of the oocyte, particularly for the PCOS patient. Coming to the endometriosis definitely it will affect the quality of the oocyte. How it affects? There will be a dark central cytoplasm abnormality, granularity. There might affect spindle also. It might affect the mitochondrial. So the endometriosis also sometime kind of the cystic endometrial cyst, sometime what we call chocolate cyst, and endometriosis 3 level grading and all that, that is definitely affect the quality of the gamete, and it can be improved by improving the endometriosis, or giving the medications or surgery. So, what are the adjuvant therapies, medical management, surgical management? What are the diagnostics marker, and what are the oocyte dysmorphism affecting the endometriosis? So, one is the granular and dark cytoplasm. There will also affect the ZP. Maybe it is a dark and thick. So, such kind of patients, even with the good male factor, preferably we should go ahead with the ICSI. Women with metabolic disorders, it's also having a insulin resistance and PCOS maybe, and this also can be categorized separately, and that also affect the follicular development and the oocytes maturation. Women with autoimmune disorders like diabetes mellitus, antiphospholipid antibodies, rheumatoid arthritis, lupus, and all these are the some factors which I can read in the net that it affects the developing oocytes in the ovulatory cycles. Genetic disorders. What are the genetic disorders a woman have that will affect the oocyte? So I have said that there will be a chromosomal disorder in case of Turner syndrome, triple X syndrome, or X chromosome, where we'll have the 45X, 45 triple X, or structural defects of XQ. So that will also affect the reduce ovarian reserve, or a primary ovarian failure, or infertility on this patient. The X-linked, a single gene disorder, which will be a fragile X, which also affects the follicle depletion in the ovaries. That lady will also have the ovarian failure or ovarian poor reserve or the less oocytes, the meiotic defects, the metabolic genetic disorders, the mitochondrial disorder. So these are all the factors which either affect the oocyte, and if it is a non-genetic disorder, probably we should go ahead with the PGT. Now, the thumb question that okay, oocytes are dysmorphic or having the abnormality, and the patient is having such and such kind of PCOS or endometriosis or advanced age. But even though with the young lady having the good mature oocytes, the oocyte does all the mature oocyte develop into successful blastocyst, and why not all the mature oocyte develop successfully? Is there any formula that we can check that why not all oocytes, mature oocytes also develop? Okay, dysmorphic oocytes, immature oocytes, or any other abnormal atretic oocyte, but all M2 oocytes will also not having the develop into a good blastocyst or the implantation potential. So what are the reason for good looking M2 oocytes that will not having a good blastocyst or a implantation potential? It one is the chromosomal abnormality, because that we are not checking with the morphology, the cytoplasmic immaturity, the mitochondrial dysfunction, the DNA damage, the hormones, epigenetic error, age-related decline, the poor follicular environment, and sometimes the oocyte will not activate by the PLC zeta, and that kind of calcium oscillations what we see when we fertilize the egg. So that may be because of the sperm factor or maybe because of the oocyte factor. Oocyte is also responsible for not activation. And if further, if we do not maintain our lab quality, the oocyte, good quality oocyte also will have affected by the high pH or high osmolarity or any lab related factors which can affect the even mature oocytes. So I can think about these 11 factors that why even mature oocyte will not develop successfully and having all the implantation failure. So coming to the lab. So, lab then and now, the IVF history is not very old. The first baby was born in 25th July 1978, and we after 58 days the second baby, and the first frozen third baby was born in Kolkata. What were the difference the lab then and now? So if we understand, because advances is happening in every field, not only in the instrumentation but procedure, expertise and experience of the embryologist. So that time we have makeshift equipment. Now we have advanced equipment. We have the tabletop triple gas incubator will be giving the controlled environment for the developing embryo, and we have the advanced consensus. We have a lab, we can observe by the chip, we can have the all monitoring in the lab for the total quality management system. So now the control in the lab is good if we follow the consensus and the SOPs. So coming to the KPIs, what are the KPIs? What we regularly follow in the lab, and what are the KPI which will be affected by the defective gamete, either it is a sperm or an oocyte. So what we check into the KPI is a reference indicator, performance indicator. So the reference indicators are two as per the consensus. What are that? So whenever a lady is undergoing the IVF stimulation, There we measure the developing follicles, and we measure more than 14 mm and less than 20 mm. This is what my SOP. And I count the follicles, and then I count that how many oocytes has been retrieved for that lady. So proportions of the oocytes recovered by the proportion of the follicles developed. So it should be 80 to 95%. If it is not there, there is something wrong with the stimulation, or there is something wrong with the pickup, that we might miss some oocytes into the follicle fluid. So this is the correct ratio. About 80 to 95% follicles should give the oocytes. Either the quality, maybe it is a GVM1, but it should give the oocyte. Then there will be a proportion of metaphase 2 oocytes. So metaphase 2 oocytes, when we denude the oocyte, we check that in that cohort, if we have a retrieve 10 oocytes, and if it is a 7 are the M2, so that is a clear that 70% are the M2. So 75 to 90% of retrieved oocyte should show that it's a mature. So that is a sign of a good ovarian stimulation. And what are the factors that affect? If you see the internal factors, it may be the age, BMI, lifestyle, and the type of infertility. Whereas in case of the external factors, by that fertility, that is ovarian stimulation, laboratory procedure, cultural conditions, and environmental condition, that might affect the oocytes. Coming to the performance indicator. So in case of performance, we check the sperm motility. IVF, if we are doing the conventional IVF, then we should see the IVF polyspermy rate, 1 PN rate if it is conventional IVF, and in that Istanbul consensus, they have given the competency value, and they have also given the benchmark value. So these are for the performance indicator for the conventional IVF. What are the KPIs, which is the quantifiable measures of performance and can be used as a decision making tool? So what are the KPIs, what we regularly use and keep a record or data for every cycle going in our IVF laboratory is ICSI damage rate. It will also show not only the ICSI damage rate will, the performance of the embryologist also. So it should be less than 10%, but preferably it should be less than 5%. ICSI normal fertilization rate, how it is calculated, I have given the formula. It is not I have given, it is given into the Istanbul. Then there will be a failed fertilization, cleavage rate, blastocyst formation rate, successful biopsy rate if patient is going for the PGTA or M or SR, blastocyst survival rate, implantation rate. How do we calculate that? For every cycle from past 30 years, I am keeping all these records. So what are the factors that affects the KPI? KPI, we know that what are the KPIs which has to be measured in the laboratory, but that KPI, it looks good on the book that this is the, value and this is the benchmark value. But do we match every month? No, because sometimes it's the cohort of patients, but if we cumulative rate, we should check and what are the factors which affect the KPI. If you check the fertilization rate in case of ICSI, it should be benchmark more than 75% of the mature oocyte should fertilize. But if it is a less, we should not immediately blame our laboratory or a stimulation protocol or the instrumentation. We should check the gamete quality. We should check the other patients going the same day, the fertilization rate, and then we should see the operator competence. Then the factors affect the failed fertilization. Generally, in case of ICSI, the failed fertilization is less than 5%, but maybe around 1 or 3%, not even 5%. In case of conventional IVF, failed fertilization is little more, but now I think in India, 100% is the ICSI cycle, so less than 5%. But if it is more, we should first exclude that The use of testicular sperm, artificially activated oocyte cycles, globospermate is very less, but that kind of patient might not have that PLC activity good, so that may land up into the fertilization, failed fertilization or a poor fertilization in case of the ICSI cycle too. Factors affect a cleavage rate. Generally, all the zygote which is fertilized, it should develop into the means it should develop into the embryo, and 40 to 60% should develop into the blastocyst. So cleavage rate should be more than 95%, but the benchmark should be 99%. If it is not happening, what we should check? We should check our culture system. We should check our other lab parameters, incubators, gases, and all that, and the quality of the gamete. But quality of the gamete will not affect here, because if the quality is poor, primarily it will not fertilize. But if it is fertilized, if it is not turning into the cleavage, then probably it is the compromised lab quality which is affect the cleavage rate. The blastocyst formation rate 40% is, but 60% if it is a good lab condition, and 60% should develop into the good blastocyst. Then there will be a biopsy formation rate. And what are the importance for this? If we keep our lab in a very good condition, we can achieve this blastocyst formation rate. Now we are coming. Why the egg quality decide the IVF success, and what are the lab KPIs and oocyte dysmorphism we'll study. So what we have seen in the consensus that if oocytes has fertilized 70% or 75% is fertilization rate, and it is not developing into the embryo, or it is a fragmented embryo, then we should check our lab that what is going wrong. And if it is implantation rate is poor, miscarriage rate is high, cryosurvival rate is poor, all these KPIs we should have that sure chart month wise, and we should check that what are the parameters which we have done. The lab KPIs which affect the like maturity rate, fertilization rate, this is again a revision, ICSI degeneration rate, implantation rate. Sometimes even embryo are arrested and not having the blastocyst at all. So what are the factors which affects and what need to be controlled? Maybe probably when we are making the dish, the media is altering the pH or osmolarity, or the oil layering is less. So for patient-specific pattern influencing IVF lab KPI, advanced maternal age, poor ovarian reserve, PCOS, endometriosis, genetic disorder, obesity, and all that, that is okay. But still, this is not always that obese patient will end up with all abnormal oocytes. I have seen a lady of 120 kgs and having a 90% of the mature oocytes. So it is upon the individualized things. The laboratory strategy, what we see as an embryologist, what it is said that there are more than 200 variables to be controlled or to mimic the in vivo kind of condition. We may not be knowing all the 200 variables, but what we know, that is also very important to keep it under the control. That one is a culture system, our gas system, our handling, the time to handle the oocytes outside, the osmolarity, even the light what we are affecting. Some labs are very extreme. I have seen few labs, when they call me for the QC, they are doing the oocyte pickup completely in a dark. They will switch off all the light. But that is also not good, because they should see the oocytes. Now what they do, they can increase the power of the microscope, that is directly affecting the oocyte. Instead of that, you can have the yellow frequency light in the lab, which is little side, and you can keep a little lighter light into the lab. But these are the few factors which very very minor, but it should not be overlooked in the lab, as I feel that being an embryologist, it's for us, it's like an exam. Once we have the oocytes in the hand, if we give 60% blastocyst, we are pass in the exam, otherwise we are fail. So the good quality oocytes, we should keep it is in a good condition till it develop into the blastocyst. So what are the lab strategies to optimize the outcome? So immature oocytes, sometimes if you are doing the conventional IVF, that immature oocytes you can keep little longer for insemination. But in case of ICSI, what my observation, rescue ICSI or rescue IVM is not going to help. Fragile ulemma, it should be gentle at the denudation. Without directly, do not use 140 or 135 denuding pipette. You use 170 and then you use 140 to denude the oocytes. And there is another school of thought that you leave the little corona cumulus ICSI. If polar body is visible, the corona cumulus is going to help into developing embryo. So do not worry about that. You should completely denude the oocyte. The abnormal zona pellucida, that will kind of use ICSI. Oxidative stress, we should not use the too much of exposure into the, we have to minimize the time handling the gametes outside the incubator. So these are all the little things. So when any junior comes into the lab, the first we said, okay, you prepare the dish, but the dish preparation is very very important, where which platform they are preparing. And if there are in the busy lab, if there are 4 or 5 pickups, they will prepare at dish at a time with the droplet culture. So by the time they will reach to the 10th dish, the first dish has changed the osmolarity. So at a time, always make sure that you should not prepare more than 2 dishes in the lab. So these are the laboratory strategy which one can use, and it will come from the experience only, and it can come with the strict SOP. This table is very close to my heart. So what I have done here is I have make it direct contact, indirect contact, and the equipment. What are the things which comes directly into contact of the gametes? That is culture media, the enzyme solution in the culture media, the ICSI needles, and the cryopreservation solution. So this we have to use very carefully. If storage of culture media is also important, I keep 2 QC parameter for even if using the medical grade incubator or a medical grade refrigerator, I keep a normal thermometer and I keep the digital thermometer also. So daily make a point that temperature should be maintained. Use the minimum vial, and if you are using the high volume, make it sure that it can be used under the supervision of the senior. The indirect contact, whatever we are using the dishes, now there are number of dishes which is either means mouse embryo tested and other quality parameter tested. Use that kind of material, because there is one recent study done into 2023 that they have checked the, we are using 14 different kind of disposables into the one IVF cycle. And if you check these 14 different disposables, we are going to add a toxic material into the gamete. So we should be very, very particular that what we are using, because sometimes when we are using the conical tube, that is MEA tested, but the lead of the conical tube is not tested. So we have to be careful that whenever we are using the disposables into the IVF lab, the incubators, the gas, because if incubator is heart of the IVF lab, the connecting tube and the regulator and the gas cylinders are system to support the heart. So we should not neglect that. What are the tubes we are using? what are the regulator we are using, and what are the type of gas. And sometimes, I have gone into that research that gas is manufacturing from what, and why we should use the 3 4 cylinder. That is all different things we comes from the experience. The equipments, we should be always under AMC, or we should keep it up to date. Incubators probably into the ICSI, injecting ICSI rings, so that the injection needle and holding prepare, the pressure will be perfect when we are doing the procedure. The level of ROS generation in the lab is high, either with the whatever 14 different type of disposables we use in the laboratory. So we have to minimize the use of the different disposables. The centrifuge, the incubators, the air quality, sometimes the even the embryologists add into it few little things that embryologists should not have applied nail polish or perfume or kind of fragrance cream and all that, because all these are VOC generated material. So this picture says so many things to be controlled in the maintain the total quality management system. The air quality is main. We should have that HVAC system, and we should have that ISO 5 or ISO 5 under the laminar flow, and ISO 7 or a class 10,000 is preferable for the laboratory. We should not have the material which generate the VOC in the lab. Preferably, we should not keep any wooden table or a wooden chair in the lab. It should be clean with the proper cleaning agent. We should not use the isopropyl alcohol or other thing. The oil overlay is also must. Sometimes, we are using that 9 mm dish, but make it little, we are little, kind of that we pour little less oil, so that droplet is not properly covered. So make it a point, see after the dish preparation under the microscope that the oil is covered all the micro droplets. And the droplet size also matters. People uses from 10 milliliter to 30 microliter, so one should have their own SOP. So complete to the conclusive remarks about the lab parameter. As oocyte quality is a primary determinant of the IVF laboratory and clinical outcomes, poor oocyte quality cannot be reversed, as I said, but its negative impact can be mitigated through optimizing the lab conditions. Careful oocyte handling, gentle micromanipulation, strict control on temperature, pH, oxygen, light exposure, use of ICSI if needed, activation of the oocyte, cultural condition, and vitrification material, and continuous monitoring of the KPI is the key to success. And as it says, this paper, that there is only one thing that is truly important in an IVF laboratory is everything. There is no shortcut to the laboratory. We have to, observe each and everything. So if you see what I have used 5 elements in an IVF lab. So what are the 5 elements for the human life? Is spirit, water, fire, earth, and air. So spirit is our culture media. Water is what our we use in the IVF lab to clean and to prepare the media. Fire is our incubator. Earth is completely our lab, and air is the air quality what we use in our IVF lab. So even for the lifespan of the human being, these 5 elements are essential, so that the tiny oocytes or tiny sperm or the tiny embryos need to be controlled by all these 5 elements. And the first and prime most important is SOP. Make the complete SOP for andrology lab, for embryology lab, for cryobiology lab. Even I have a SOP that if by chance if you spill the follicle fluid into the floor, how to clean it. So how to achieve the benchmark values for the KPI? first and prime most important. Patient biology is very important, but it's not that if a bad embryo is there and you just blame that, oh, patient is advanced age or patient is having endometriosis. No, it's not correct. We have to check all that clinical factors. We all should check all the embryological factors instead of blaming patient or a clinician or the embryologist or the paramedical staff. We all work as a team, then only we can improve, because team is a mantra for the good outcome in the IVF lab. So, why a good team and the good communication is key to success, not in only in IVF but all the sphere of the life. A clear cut communication will solve majority of the issues. At first consultation, what are the patient should be explained by the counselor. If it is a normal counselor, if patient is undergoing for any kind of genetic PGTA or PGTM, then there should be counseled by the genetic counselor. Then there should be informed consent about the ART Act. Every employee of the IVF clinic should be aware about the all the consent form, that what are the consent forms should be signed for the which procedure. Then there will be patient should feel comfortable. Then there will be a risk counseling, emotional support, lifestyle advice, poor prognosis discussion, failure communication, and about the confidentiality. So these are the few factors that counselor job is most important in an IVF laboratory, because sometimes or little emotional support will help them to control their anxiety, and that will help us to have the good hormonal control. And sometimes even I have seen the patient having the good blastocyst transformation at failure, and the second cycle they will come automatically with the normal conception. That is possible only because of the good counseling. Treatment planning, monitoring and follow-up, lab clinic coordination, risk management, multidisciplinary care, documentation, quality assurance, post-cycle review, ethical practice, and continuity of the care. I have seen few clinics take care till that a patient delivered, but it is not possible because the patients will go. But till the pregnancy, we should see that our data. So clear communication and care management is very, very essential. It will, reduce the emotional burden and the psychological burden patient undergoing that. And they are also aware of about act and what are the consents to be signed and all that. So it is very, very important. So what are the current strategy for oocyte quality enhancement in an IVF laboratory? So one is a individualized ovarian stimulation. Probably maybe next session by Dr. Purushottam will cover this topic. Antioxidant supplement and DHEA priming, growth hormone, that is for the clinical side. But what as an embryologist we can do in the lab is we can optimize the cultural conditions with keeping our lab with under the total quality management system and the following the strict standard operating procedure. Then there will be oocyte accumulation freeze also. We should be aware about the which patient is going which, and particularly the patient if is any undergoing any kind of genetic analysis, PGT and all that, that has to be taken with primost care. If we are using any add-on procedure, that procedure should be explained to patient very clearly that this is the advanced procedure we are using for the patient, either if it is in embryology like at oocyte activation or kind of any hyaluronic acid or Pixie or IMSI or whatever. If we are using the microfluidics, or that has to be clearly told to patient, and preferably we should take the consent for it. So these are the current strategy. What are the future direction in oocyte quality enhancement is first is morphology, that what we are seeing. But the mitochondrial DNA quantification is one of the future direction to check the developmental potential of the oocyte. The under research is biomarkers in the follicle fluid, which is also a good parameter to check the quality of the oocyte, that omics, what I discussed earlier, proteomics, metabolics, and all that. Finally, gene editing is also one of the thing. So oocyte quality remains clinically critical limiting factor. Current strategy mainly focus on optimization and selection. We cannot reverse the poor quality, but we cannot further deteriorate it. There are many current procedures we should be, understand and follow in the laboratory. And the future, we have to keep a space with advance happening into the ART field, and with the studying all that RCTs and Cochrane analysis. And if we are going ahead to include that procedure in our lab, we should have the proper scientific evidence and continuous research and innovation. We should be aware of things. The latest is artificial intelligence. So should we add for the oocyte? Of course, I feel that AI is a future for ART lab, not only for the checking quality of the sperm for ICSI, or selecting sperm for the ICSI, or selecting a oocyte, or selecting blastocyst for transfer, but AI will help us in many other things, like individualized ovarian stimulation protocol. So because that has a major advances also, but we should also understand the little kind of disadvantage also. There are many, there are one or two AI available for the ART bank, gamete bank, and for the patient also. And that can, we, if it is coming in our kind of thing, we can budget or something, we can probably include in our IVF section to selection of the oocyte, and we can check that oocyte, that oocyte which we have selected through AI has developed in the which kind of blastocyst, and whether it is implanted or not. That kind of record also we can keep. So these are the few studies which has been done, that can be used for selecting the oocyte, either for the self cycle or for the gamete donation. So should be AI a part of the oocyte quality assessment? I feel yes, we should include that, but with the precautions. What is the need of an hour? So we should have the development of robust and reliable system for the screening of oocyte quality. Every embryologist, either junior or senior, should be aware about all the oocyte dysmorphism and laboratory management. We should keep the space with the recent advances, and the morphology is the best criteria till today. Understanding the patient related trends also will allow us to use that gamete of this patient might be having this kind of thing, but it is not always true and the random that endometriosis patient will have all the dysmorphism, or a PCOS patient will have all the immature oocytes. No, it is a patient specific. But yes, every dysmorphism, if it is a severe, we should culture that oocyte separately. But it is not always, as I said, sometimes a lady of 42 years of age is having a good ovarian reserve, and sometimes the young patient will have the poor ovarian reserve. So it is an all individualized protocol. But what we should see in the lab, that oocytes should convert into the good blastocysts. So this is my final slide. Oocyte developmental competence is influenced by nuclear maturity, as we all know. It will be affected by the size of the oocyte, but what we cannot see routinely is a genetic makeup, the metabolism rate, and the respiration rate of the oocyte. But if we control the lab parameters by controlling all the SOPs, and we are aware of that, what are the oocyte morphology and what are the dysmorphism affect the fertilization rate and cleavage rate, then probably we will be happy like this in the after the result, if we see. So thank you very much. I welcome all the questions if you have.
Wow, thank you so much. What a brilliant start to 2026 and a wonderful masterclass. And I'm sure it has been quite exhausting for you talking 1 hour, but then we really enjoyed it every bit because everything was so, the entire textbook was concise and you touched upon all the aspects of oocyte morphology, the patient factors, how we should practice as a clinician and how we should practice as an embryologist, how to maintain lab KPIs, what is the future direction, so on and so forth. And your slides are really like excellent, comparing all the evidences in one slide, all the
Oh, you know, it's
meta-analysis. It was truly enriching 1 hour masterclass with you. Now, and I extremely extend our heartfelt gratitude for taking this lecture for all of us. I now request Dr. Sindhuja Srinivasan, who is a lab manager at Sri Chakra Fertility and a very eminent and an able embryologist, to please kindly take over the Q&A session and then proceed further, please.
Thank you, ma'am. Ma'am, Charulata, ma'am, it was very, very nice. I think the slides were also very informative. In each slide, there was so much information, and it was like seeing everything at a glance. Thank you, ma'am, for the time you've taken to present this. Ma'am, we'll quickly go to the questions on the chat box. So the first question is, what could be the reason behind the day 3 arrest of embryos of a patient in 2 cycles, while there was blastocyst formation for other patients in the same cycle? I think you touched upon it here.
Yeah, so see this, that's what I say, that if oocyte is not fertilizing and not having the zygote formation, probably it is a patient related. But embryo arrest, sometime it may be because paternal genome activates from the day 3. So if we see that, we should see the paternal factor, not always the maternal. So we should see that it is a testicular sperm or what, that one has to be checked before we go ahead with the lab condition, and then probably we should see the lab parameters.
Okay, ma'am. How do you differentiate FERT failure caused by defective intrinsic oocyte activation versus subtle sperm factor when ICSI FERT rates fall despite good morphology? What KPI should alert us, FERT rate or abnormal FERT rate or rescue ICSI rate?
So if it is generally, as I told you, if it is a conventional IVF, fertilization failure rate is little higher because here, but in case of like ICSI, we are bypassing all other, parameters like defective ZP and all other thing. But in case of the this ICSI, if it is a complete fertilization failure, then we should check the sperm morphology. If it is sometimes a severe cryptozoospermia or mainly globosospermia, but having globosospermia is completely less, where there is a PLC zeta deficiency. Then this, but in case of this, there are 2 3 methods which we can overcome this. One is a little advanced ICSI. There is a nice paper by Thomas Ebner. What he said, that to activate the cytoplasm, you know you one in a ICSI, you go till 3/4 of the oocyte, correct, and you aspirate the cytoplasm. So we should aspirate the first, you aspirate the cytoplasm, disperse it again into the oocyte, again you take the cytoplasm. So this is one of the modified that is, he said it is a modified ICSI method, instead of using a calcium ionophore or something which is so far study says that there is no side effects or something, but that is one of the thing. And artificial oocyte activation with calcium ionophore also acts wonderfully to activate the oocyte. So these are the two lab strategy to overcome. One is a modified ICSI and one is a oocyte activation by calcium ionophore. That there is another method called electrical oocyte activation, but we do not do in our lab.
Ma'am, can you just repeat that modified ICSI procedure just once, ma'am, for the benefit of all?
So you can see there is a modified ICSI by Thomas Ebner. So
Okay.
what he has shown with the pictures in that paper. So
Yes.
what I do in the modified ICSI is, how do you do ICSI? You take the needle inside and you aspirate the cytoplasm, correct? And then you expel the cytoplasm into the oocyte. So that procedure you have to do twice, very fast.
Okay.
So that will, and instead of middle, you go little 3/4, but that should be done with the experienced head. You should not touch the other side of the oocyte and degenerate the oocyte.
Yes.
So that also wonderfully helps to overcome the oocyte defects.
Okay, ma'am. Ma'am, someone has asked benchmark values based on WHO.
This is Istanbul consensus.
Yes, yes. So WHO doesn't really hasn't given guidelines for the benchmark
No.
values. What could be the probable
WHO has given for the semen, sperm parameters.
Yes. So what could be the probable reason for failure of good day 3 embryos to fail to form blastocysts? Ma'am, you have covered that. And how do we maintain different KPI of oocyte quality for cycles with different stimulation protocols like dual trigger, long protocol, antagonist?
See, protocol is whatever it is. It is, we are not going to table wise keep the different protocol giving different oocyte. No, we are seeing the abnormality of the oocyte and we are categorizing that way. So that clinical parameters we are not checking. We are only checking that this is a granular cytoplasm, there is a SER, this is the this. You might correlate with the stimulation protocol, but no, we are not going
Our
to
observations are
check
not
and
going
yeah.
to change. Is it compulsory to check fertilization after ICSI or to avoid exposure? Is it okay to check after day 3? What will be the difference?
It is again individual approach. In my lab, I do check because sometimes even in the ICSI, you might see the, triploid or polyspermy. To just avoid that kind of thing, I quickly check the fertilization. That is my practice, but it is again individualized approach because their lab SOP.
Okay, ma'am. Just one more question. In your speech, you told you should not use isopropyl alcohol in cleaning. Question mark. I'm not sure.
Yeah, one should not use isopropyl alcohol. Who is using?
Yes, ma'am. Ma'am, last question. How can we reduce?
Even for when they are doing PGT or something, there is a different kind of material is using DNAs or something, which you can clean the laminar so that other DNA contamination should not come.
Okay. How can we reduce the blood clots coming in the follicular fluid while scanning in order to reduce their intrusion? I'm not sure of
I
what.
think it's more to do with the technique of aspiration, your aspiration pressure and everything. But the question here should be like if the embryologists receive a
Yeah.
follicular
So
fluid with
what I
more
do
blood
is,
clots, then how do you handle
yeah.
it?
So when senior embryologist is doing, I have a quick method. Someone use BD syringe with a needle to cut off that kind of thing. But for me, I use the plain dish and I cut it with the pipette. So I avoid that cumulus. Otherwise, you can just cut it with the needle, but see that BD syringe and needle, but see that you should not harm the oocyte. So you should precisely get rid of the clot.
Okay, ma'am.
But hardly you will see it can, with repeated pipetting only that blood clot will be washed off.
Many have thanked you for the excellent explanation and presentation and for your information and time, ma'am. So all these
Thank
questions
you.
I've taken from the chat box. Thank you so much, ma'am. It was very
Thank
holistic,
you. Thank
actually.
you. And all of you have happy New Year and good night.
Thank you,
Thank you
ma'am.
so
Good
much.
night, ma'am.
Thank you, all the delegates. We will see you soon in the next masterclass. Thank you.
Thank you.
Thank you, ma'am, so much.